Now, as the blood pressure starts to fall, if shock is developing, there are physiological compensations. And there are two types of physiological compensations. There are endocrine-based compensations, and there are neurological-based compensations. So let's think about the endocrine base first. What's going on here? Well, in the kidney, the afferent arteriole, as you probably know, takes blood into the glomerulus. And in the afferent arteriole, before the blood goes into the glomerulus, is the juxtaglomerular apparatus. Juxta means beside. It is the apparatus beside the glomerulus. And what this does is it constantly senses the pressure of the blood passing through the afferent arteriole. And if the pressure of the blood passing through the afferent arteriole drops, the juxtaglomerular apparatus in the kidney responds by producing renin. So if the blood pressure drops, renin is secreted by the kidney. So here we have a kidney. And if the blood pressure starts to drop, the kidney secretes renin. So the amount of renin in the blood is going to increase. Now, in the blood already, there's a protein produced by the liver called Angiotensinogen. So Angiotensinogen, a protein present in the plasma, produced by the liver, circulating around, and it doesn't do very much. It's not a physiologically active molecule, it just circulates around in the blood. So in the blood already, there is angiotensinogen. Just circulating around. But when this angiotensinogen is acted on by renin, the renin converts the angiotensinogen into angiotensin type 1. Angiotensin type 1. So renin has the effect of facilitating the conversion of inactive angiotensinogen into angiotensin type 1. And angiotensin type 1 is a fairly short protein, it only contains 10 amino acids. But angiotensin type 1, despite being a small protein, is physiologically active. And it will cause some vasoconstriction, and it will also cause some increase in the release of aldosterone from the adrenal gland, from the adrenal cortex. And aldosterone will increase the amount of sodium which is reabsorbed from the renal tubules. So if you increase the amount of sodium which is reabsorbed from the renal tubules, there's going to be more sodium in the blood, and because sodium is osmotic, it's going to attract water into the blood. That's going to increase the intravascular volume, that's going to increase preload, the venous return to the heart, and if you increase the venous return to the heart, that will increase cardiac output, because cardiac output is determined by venous return, as we've already talked about, as described by the Starling's law of the heart. But it doesn't do this to a massive extent, it does it to some extent. So angiotensin type 1 causes some vasoconstriction and some increase in intravascular volume. But as the angiotensin type 1 goes through the lungs, the angiotensin type 1 is converted into angiotensin type 2. Angiotensin 1 converted into angiotensin type 2 as it passes through the lungs. And the reason this happens as it passes through the lungs is in the lungs there is an enzyme called angiotensin converting enzyme, ACE. Angiotensin converting enzyme. And the angiotensin converting enzyme, what it actually does is it cuts 2 amino acids off the 10 amino acid unit, which is angiotensin type 1, and converts it into an 8 amino acid unit, which is an angiotensin type 2. And angiotensin type 2 is a massively physiologically active molecule. It's a very active molecule, way more active than the type 1. And it has several effects. And actually, just before we go on, ACE, you're probably trying to think about where you've heard of it before. It might be that you've given out drugs called angiotensin converting enzyme inhibitors, which of course are given for hypertension, amongst other things. So the angiotensin converting enzyme is completely physiological, produced by the lungs, and has this effect. Now, angiotensin type 2 is very physiologically active. It is a profound vasoconstrictor. It constricts down the blood vessels, particularly the arterioles. And when you constrict down the arterioles, that's going to increase peripheral resistance, therefore increase blood pressure. And angiotensin type 2 also has some venoconstricting properties, which means it closes the veins down. That increases the central venous pressure, and that increases preload, which also helps to increase venous return to the heart. Like angiotensin type 1, angiotensin type 2 stimulates the adrenal gland to produce more aldosterone. But it does it very much more than angiotensin type 1. So the adrenal cortex is producing quite a lot of aldosterone when it's stimulated by angiotensin type 2. That increases tubular reabsorption of sodium, that increases reabsorption of water, and that helps to increase blood volume. And a final effect, angiotensin type 2 works on osmoreceptor neurons. Now, osmoreceptor neurons are in, or near, probably in, the hypothalamus. And when these are stimulated, it generates thirst. So the patient feels incredibly thirsty. And you may have noticed this, especially in your hypovolemic patients, especially Burns patients. They are desperately thirsty. And this is partly an effect of the angiotensin type 2 stimulating the osmoreceptors in the thirst centres of the hypothalamus. So if the patient drinks, that can also increase intravascular volume. So angiotensin type 2, very active, arterial vasoconstriction, venoconstriction, increasing aldosterone, therefore increasing blood volumes, and also stimulating thirst. Now, the other endocrine response I want to talk about is antidiuretic hormone. And antidiuretic hormone is also called vasopressin. In fact, vasopressin was the first name it was given because it constricts the blood vessels. This activity was first discovered and the hormone was given the name vasopressin. Because if the blood volume drops, that will cause more antidiuretic hormone, or vasopressin, to be released from the posterior pituitary gland. And the vasoconstriction, of course, is going to increase the peripheral resistance. So if blood volume drops, more antidiuretic hormone will be produced. And also, if blood osmolarity increases, that is, if the amount of water in the blood is reduced, that will also stimulate the release of antidiuretic hormone. And antidiuretic hormone circulates in the blood to the renal tubules. In the renal tubules, it causes increased reabsorption of water from the glomerular filtrate. If more water is reabsorbed from the glomerular filtrate back into the blood, that's going to help to maintain intravascular volume. So this hormone is working in two ways, two compensatory mechanisms. One is that it's going to be vasoconstricting to maintain peripheral resistance. Another is the antidiuretic effect. Anti, of course, is the opposite of a diuretic. A diuretic will increase urine volumes, an antidiuretic will decrease urine volumes. And because the urine volumes are decreased, more fluid is preserved in the blood. That's going to help to conserve intravascular volume. That's going to increase preload to the heart by increasing venous return. So two mechanisms there, the antidiuretic effect and the vasopressive effect.